No sound. We can't hear.
Oh, sorry.
Now, thyroid thermoablation. The goal of thyroid thermoablation is to elevate tissue temperature in order to create zones of irreversible cellular damage. Thermal ablation heats tissue to cytotoxic level through which cell death is caused. Afterwards, the created coagulative necrosis is degraded by the patient's own immune system. At temperatures between 60 and 100 Celsius, nearly immediate tissue coagulation induces with irreversible damage caused to tumor tissue. But while temperatures greater than 100 and 110 Celsius result in tissue vaporization and carbonization. And here are a chart about thermal ablation. The main goal is between 80 and 100 Celsius heat, and then occurs cytotoxic effect, cell death, coagulative necrosis, and the coagulative necrosis destroyed and phagocytated by the immune system macrophages. But if the heat is above 100 Celsius, it occurs carbonization, and the immune system can't phagocytate by macrophage. What are the advantages of microwave ablation compared to radiofrequency ablation? The first is we have higher temperatures in the ablation zones. We can do in the same time larger ablated tissue volumes. We have optimal heating in cystic nodules and in hypervascular nodules, in toxic adenoma. We have less pain during the procedure. In microwave ablation, we have no ionic current passing through the body as in radiofrequency ablation. Tissue impedance doesn't matter in microwave ablation, but we have not inhibitor effect on preventing carbonization in microwave ablation. Therefore, we must use in microwave ablation low watts, example between 20 and 30 watts. We have no heat sink effect, and microwave ablation does not require the placement of grounding pads. Therefore, we can use in pregnancy and hysterectomy. Selecting the right patients for thyroid thermal ablations. In every patient, if we need thermal ablation in benign thyroid nodules, we need a biopsy in the last 2 months. In some guidelines, they offer 2 biopsies, but I think in the clinical practice, 1 thyroid biopsy is enough. We have many ultrasound-guided thyroid thermal guidelines, but the main guidelines is the Korean guidelines, and Dr. Bayek, and he's the pioneer of thyroid ablation guidelines technique. And the guideline of Korea, if we see, the indication is in thyroid thermal ablation, patients with benign thyroid nodules production septum or cosmetic cancer. The second indication is autonomous function thyroid nodules, toxic or pretoxic. And potential indication is primary thyroid cancer in patients who refuse surgery or are unsuitable for surgery, or recurrent thyroid cancer in the thyroidectomy bed in cervical lymph nodes. Contraindication is follicular neoplasm or malignancy on FNA, but I know that in Chinese and Korea guidelines, in this guideline, they do it for papillary carcinoma, but in some guidelines, they don't prefer it. And relative contraindications are pregnant and severe heart disease or pacemaker, but in these cases, we can use microwave ablation. In the clinical practice, indication is nodules that contains more 50% cystic components, solid and mixed tip nodules under 30 cc, because above 30 cc, we need a second system of thermal ablation. We must explain the patient about this. Autonomous toxic nodules, growing nodules, thyroid nodules plus previous thyroid surgery, patients of risk of general anesthesia, and parathyroid adenomas. And we have some in which nodule must be choice for thyroid thermal ablation for a good volume reduction rate. The best candidates are spongiform echostructures, nodules with liquid component, intense peripheral and intranodal pattern vascularity, soft nodules. In my clinic, we use for every thyroid nodule before the ablation shear wave elastography, and we look if it's a soft nodule or a hard nodule, and we choose nodules that have the shear wave elastography volume below 30 kilopascal. And in this nodule group is a better volume reduction rate. And nodule volume below 10 cc, in this group, we have a good volume reduction rate. And there are some technical factors that affect the volume reduction rate. That the first is the operator skills and experience. The second is in microwave ablation, we use low watts to avoid carbonization and for a higher volume reduction rate. Ablation of the peripheral margins of the thyroid nodule is very important because the mostly regrowth point is their part, because the vessels, the feeding vessels of the thyroid nodule entry from the peripheral margins. And we must use hydrodissection. It's a better ablation of nodule margins. And if we use hydrodissection, it protects from the complications by preventing thermal damage to structures such as recurrent laryngeal nerve and nervus vagus. There are some clinical situations and some patients. The biggest group is the autoimmune thyroiditis group. We have many patients. So, and in patients with high thyroid antibodies before the procedure, we must be careful in this patient group because in this patient group, the thyroid tissue destroyed after ablation. In some patients, release of antigenic material such as TCHR from follicular thyroid cells, and this trigger autoimmune inflammatory process like autoimmune hyperthyroidism and Graves' disease. And the second group is there are some patients, there are hormone levels are in normal limit, but in some hypervascular nodules, 5% of toxic adenomas may present as bacterioids. In these patients, if we see in the ultrasound examination atrophic thyroid lobe in the contralateral side, we must, it can be suspect toxic adenoma, and in this patient group, we must request a thyroid scintigraphy. And the third group is the hypervascular solid nodules. In this group, after ablation, maybe we can see thyrotoxicose because of the destruction of the follicular cells in the ablation nodule. And in some cases, it's my experience, in postpartum or lactated female patients, the hormone levels are very different in the women. And in these cases, we have a high risk for thyrotoxicosis in hypervascular nodules. And therefore, we don't do thyroid thermal ablation in the postpartum or lactating female patients. And volume reduction rate is very important. The treatment goal of volume reduction rate is above 50%, but in the clinic practice, it must be minimum 70%. And volume reduction rate is higher in cystic nodules and solid nodules. It increases, the volume reduction rate increases as electrical volume decreases. We have a clinical trial in my clinic, and we found that nodules with a shear wave elastic volume above 60 kilopascal with macro calcification have a volume reduction rate below 50%. And another point is we follow up the nodule with cc or milliliter because it is very important. Small difference in the diameters affect the because the nodule is a 3D mass. Small difference in the volume diameter measurement affect the cc very much, as we see here. And this is the follow-up form of my clinic. And this it's very important, I think, because the thyroid thermal ablation is a new technique. It is good for information for the another clinicians and physicians, and a good follow-up for the patients. We draw the nodules site here, and then we write it, and in which lobe is it, and then we write here the nodule volume, nodule stricture, nodule vascularity, the elastography volume, the cosmetic score, the symptom score, and what we use, and the processing time. And after 1, 3, and 6 months is the control. And the control, we write again the nodule volumes, nodule vascularity, the elastography value, and the cosmetic and symptom score, and we write the volume reduction rate. In the beginning, we only use local anesthesia. We don't use pseudo-analgesia in my clinic. And therefore, we give, mostly we use pre-local hydrochloride, and we give maximum 40 cc. We use local anesthesia between the strep muscle and thyroid capsule. And the second, before the thermal ablation, we look at some anatomic variations. The first, what we look is nervus vagus. And here are the diagram about the types of nervus vagus variation. Normally, the nervus vagus is in the carotid sheath in the 2 o'clock or 3 o'clock. This is type 1. In type 2, it is on the 12 o'clock. In type 3, it is on 10 o'clock. And in type 4, it is 6 o'clock. But type 3 and type 4 are danger for thyroid thermal ablation. In this, we can make thermal injury. Therefore, in type 3 and in type 4, we must use hydrodissection. Here is another anatomic variation of the middle cervical sympathetic ganglion. Normally, the middle cervical ganglion is lateral to carotid artery, but in some cases it is on the medial part, and when we see this, we must use hydrodissection. And another important point is in patients with a history of total subtotal thyroidectomy, and this is a big group because the surgeon don't want again operation in this group, we must use hydrodissection because the course of the recurrent laryngeal nerve changed completely in this patient group. Here is one of my patients. It's my complications. In the beginning, we don't use hydrodissection, and we see here damage of the cervical sympathetic chain, and it results with Horner syndrome, meiosis, pitosis, and anhidrosis. And here is another of my patients. And we have here right vocal cord palsy because we have thermal damage of the right recurrent laryngeal nerve. And we look for every patient before the procedure to the vocal cords and after the procedure to the vocal cords. And if we see this at the procedure, if the patient has voice changes or if the patients, we see in the ultrasound examining that the patient has vocal cord palsy, we use 20 cc cold dextrose and prednisone neural mixture and inject it on the danger triangle to the recurrent laryngeal nerve, and mostly it resolves in a small time. For avoid these complications, we use now in every patient hydrodissection. And here is a paper from China, from Dr. Shire. And in his paper, he said that the hydrodissection zone must be minimum 3 millimeter between the thyroid nodule and the vulnerable structure. And here is an example of my case. Before we use local anesthesia between the thyroid, and here we use hydrodissection between the carotid artery and the thyroid nodule. We give here dextrose and make a safe zone. Again, we navigate the needle and then we push dextrose. Sometimes we give 100 and 150 cc, but mostly I use only 40 and 50 cc cc dextrose. And here, another case, we use transismic approach and we give here 20 cc lidocaine between the thyroid capsule and strep muscle. And then the carotid artery is close to thyroid nodule, and we use a perpendicular approach, and then we navigate the needle, and then we give here example 20 cc cold dextrose, and then we have here a safe area for if we do hydrodissection. Here is another patient. We give here lidocaine again. I usually use 1 entry point, and if I give the lidocaine, then I change not the needle, and I give it the same needle dextrose, and here I navigate the needle, and then I push 20 cc dextrose, and then we have here a safe zone for hydrodissection, as we see. Another case, here we have right parotid adenoma. It's close to right carotid artery. In the beginning, we go with the needle perpendicular and push here dextrose, and we separate it from the carotid artery. And after that, it is important that we give the dextrose below the adenoma, and then we navigate it and give below the adenoma 20 or 10 cc dextrose. And after this, we go to the second step. Second step is we use the lateral approach, and with the lateral approach, we give again 40 or 60 cc dextrose. And now we have a lateral and below side safe hydrodissection area. And after that, we try the parotid adenoma with the antenna, and we ablate it with a quick and safe method. What we can use for hydrodissection? Normally, we use crystalloid liquids. As we know, we cannot use saline in RFA for do the ionization. We mostly use dextrose. But the disadvantage of crystalloid fluid is when occurs the hydrodissection area, the fluid absorption is very fast, and the continuity of the safe hydrodissection distance is short. And sometimes we can lose the safe area. Therefore, we have a clinical trial in my clinic. We try colloidal fluids in some patients that have big thyroid nodules. And if the procedure is longer, we try this group. The advantage of colloid fluids is very well. Normally, we use it in hypovolemic shocks in the emergency department. It is an iso-oncotic liquids. It's a hydroxyl starch, and the molecular weight is very high. It has the same cost as a crystal fluid, but the advantage of colloidal fluids is the absorption is very slow compared to crystalloid liquids, and the continuity of the safe hydrodissection distance is very long. And here's an example of a case. We have a left thyroid nodule, and we use 20 cc volume, and the hydrodissection area is diameter is 4.9 millimeter. After 5 minutes, 4.6. After 10 minutes, 3.9, and after 20 minutes is 2.5. As we know, for 20 minutes we have a safe hydrodissection area. Thyroid nodule microwave ablation. I use the trademark of ECHO, and the microwave unit consists of a microwave generator, flexible low-loss coaxial cable, internally cooled shaft. The microwave antenna is 70 gauge, 10 centimeter shaft, and the activity for thyroid ablation is 3.5. And the shaft is coated with polytetrafluoroethylene to prevent tissue adhesion. The generator capable is producing of between 1 and 200 watts of power at 2,400 50 megahertz in the form of pulse or continue. Normally, in liver ablation mode and lung ablation, we use 50 and 60 watt, but in thyroid ablation, to avoid and minimize the carbonization, we use 20 and 30 watt energy. And to prevent shaft overheating, this sweat water is circulated through the dual channels inside the antenna shaft, and we use cooling shaft. Many in the literature, they write that we must use transisthmic approach, but sometimes we can use lateral or craniocaudal approach. It depends on the location of the thyroid nodule and the skills of the operator. There are two techniques, mooring shot techniques and overlapping technique. Normally, we use overlapping techniques in liver ablation, but in thyroid ablation, we must use mooring shot technique. The overlapping technique is for non-cooling ablation systems. The disadvantage of overlapping technique is that we cannot ablate the periphery margins, and the risk of the thermal damage is more higher in overlapping technique. And here are two examples of my first cases. In these cases, I use non-cooling thermal ablation systems. And in these systems, as we see, we cannot ablate it entirely the whole nodule. And we have here three carbonizations channels. And here we use microwave cooling system. And as we see, we give in the beginning lidocaine under the strap muscle. And then we use hydrodissection between the carotid artery and thyroid nodule. And after that, we begin after the posterior inferior part of the thyroid nodule from posterior to anterior and from inferior to superior. And if we see the bubbles, we move back. Here is another example. I give here dextrose and make a safe area for hydrodissection. And then I go to the posterior inferior part of the thyroid nodule. And here we see the nervous fibers. It is on the 2 o'clock, but we have here a safe zone. And then if I begin of the posterior inferior part, in this part, my moving is more faster because we are now on the, we are close to the laryngeal nerve. And if I finish to the posterior inferior part, then we go to the next step, and then we try to the middle part of the thyroid nodule. And if we see the bubbles, we move back. Here is another example. This is a toxic adenoma. We have a research paper. In this research, we compare the effect of microwave ablation and radioactive iodine therapy in autonomous functional thyroid nodules, and we find that they are both effectiveness, no difference. And as we see, it was a very hypervascular. After the ablation, we don't see any Doppler signals. And there are some patients. This was a young lady. She had a right spongious nodule in the left lobe, and the nodule volume was 90 cc. We used microwave ablation. After 2 months, when we make a control, the finally volume is 3.5 cc, and the volume reduction rate is 96%. And this is a patient from Nigeria. She comes to your clinic, and she had a very big thyroid nodule in the left node, 156 cc. It was microwave ablation, and after 4 months, it was 21 cc, and we have a volume reduction rate 86%. There are two cases. The first is after thyroidectomy. The second is after thyroid ablation. This is very minimal invasive procedure. Thank you for your listening. This is my hometown, Ontario. Thank you for everything.
Thank you, Dr.